Welcome to our podcast, Oncology Morning Commute, PD-L1 expression, who are the best candidates for immunotherapeutic agents? Morning Commute is developed in collaboration with At Point of Care and Projects of Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Merck. In this podcast, Beth Sandy and Marianne Davies take a look at PD-L1 expression and immunotherapies. Who are the best candidates for these therapies? Information about the faculty and disclosures can be found by visiting morningcommutepodcast.com/NSCLC5. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Beth Sandy is a nurse practitioner with the Abramson Cancer Center at the University of Pennsylvania, Philadelphia. Marianne Davies is an associate professor of medicine and a nurse practitioner at Smilow Cancer Hospital in the Yale Comprehensive Cancer Center in New Haven, Connecticut. I am Candace Hoffman, managing editor of Morning Commute. Beth Sandy will begin our discussion.
All right, Marianne, welcome back again. In our last podcast, we talked, a lot about molecular testing in non-small cell lung cancer. And one of those things was looking at PD-L1 expression level, which we get by immunohistochemistry. And so now we're going to focus really more on those patients who are biomarker negative, but what are their PD-L1 levels and how do we select patients for immunotherapy? Let's start off by the basics. Is there anyone, Marianne, you would not give immunotherapy to, regardless of PD-L1 status?
Yes, certainly. So you already mentioned it. Anybody who's got a driver mutation or genomic aberration, we would not move to immune therapy as they should be receiving that targeted therapy. There are other candidates, perhaps patients that have rapidly growing disease or extensive disease. We would likely not select monotherapy for immune checkpoint inhibition because we know the time to response for immune checkpoint inhibition is longer than cytotoxic agents. So the extent of disease and the rate at which a patient's disease is progressing will help guide us in terms of our initial treatment.
That's a really great point. So you're saying you would want to, give immunotherapy with the chemo to get a faster response because single agent immunotherapy might take a little bit longer?
Absolutely. And so that is part of our decision making. It may sometimes take even 8 weeks, 12 weeks, sometimes even longer if you were to use monotherapy to see a response to immune checkpoint inhibition. And so for patients that have really bulky disease, we may need to have something that is either working in combination or certainly working a little bit faster. There are other patients perhaps that are not candidates for immune checkpoint inhibition, and those are patients that have underlying, let's say, autoimmune diseases which still require active immunosuppression, or those that have immunosuppressive therapy for other reasons, such as organ transplant, stem cell transplant, et cetera. But those aside, if they do not have those other contraindications, then if they have greater than 1% of PD-L1 expression, typically we will move to either a combination or monotherapy. And for those patients that have PD-L1 expression of greater than 50%, we have a higher tendency to move right towards monotherapy with immune checkpoint therapy.
One thing I would interject and say is with the biomarkers, I would, in my practice, KRAS, often we would use immunotherapy and chemo up front since that drug is approved in the second line setting. And BRAF, you can make an argument as well. It's approved, the BRAF inhibition is approved either first or second line, but these patients often do well with chemo and immunotherapy too. So I think the ones that we typically will use frontline, EGFR, ALK, ROS1, MET and RET, definitely you can make an argument for, but the KRAS, we would still probably use immunotherapy and chemo up front, and the BRAF possibly as well. And I would definitely agree with you. I'm not giving this to a heart transplant patient, patients that require that immunosuppression, I would be very afraid. But I think your patients with, fairly controlled rheumatoid arthritis, we're able to probably give it and work with their endocrine or rheumatoid doctor to manage this. I would agree with that. So back to the patient selection, like you were talking about. Let's start with the 50% and higher. Typically, these are the patients that are likely to do better. There are several drugs that are approved in this setting, really all of them. And the question of whether or not to use it as a single agent or chemotherapy, you kind of just touched on. Most of the time in my practice, we will go with a single agent, unless, like you said, you need that faster response, like if they're short of breath or coughing up blood, maybe add chemotherapy to it. Do you have a preference on drug to use in those 50% or higher? We know that pembrolizumab, atezolizumab, cemiplimab are all approved as single agent. You can use the combination of ipilimumab and nivolumab also. So there's so many drugs to choose from here. What are your thoughts in that 50% or higher patient population?
So that can be, a challenging question. Typically, at our facility, we tend to go with pembrolizumab in those patients that are greater than 50%. Part of that has to do with our comfort level, and it was one of the first ones that was approved for monotherapy. But as you said, we do have an opportunity to use each of the agents in monotherapy. So pembrolizumab, atezolizumab, and cemiplimab. So it's oftentimes just a preference of provider in terms of what is used.
Do you see a major overall survival difference between those three single agent drugs in studies?
From the data that, when I look at the, Keynote study, particularly Keynote 042, and then also from the Empower 110, fairly similar overall survival and progression-free survival for both of those agents. The overall survival from cemiplimab had not been reached at the last chance that I had to review the data. So that would be our first choice. For those that really are in the 1 to 49%, those patients, typically we would do combination therapy. So a choice would be either pembrolizumab with chemotherapy, and the specific regimen is actually going to differ based on whether or not somebody has non-squamous non-small cell lung cancer versus squamous non-small cell lung cancer. And the other choice we have for combination in that population would be the 4-drug combination based on the Empower 150, which is the atezolizumab, bevacizumab, and chemotherapy in the non-squamous.
So that's all 4 drugs together, you're saying?
That's correct. In my experience, it's actually been fairly well tolerated for patients. The addition of the bevacizumab, which is the monoclonal antibody anti-angiogenic agent, does not really add a significant amount of toxicity for those patients. But again, that is a defined population. It's not to be used in patients that have squamous, because we know the bevacizumab is contraindicated in that subset of patients.
Yeah, and it's funny, I think this PD-L1 level 1 to 49%. So, and just to remind our listeners, it's about a third of each. So about a third of patients are going to be negative for PD-L1 with non-small cell lung cancer. About a third are going to fall into that 1 to 49%, so these minimal expressors. And then a third will be in that 50% or higher. So I think in that middle category there, these drugs, pembrolizumab is approved as a single agent for 1% or higher. However, a lot of us in the lung cancer community don't feel that that's really strong enough data as a single agent. I think where it comes in handy for me, if I have like a patient who's elderly, who I don't particularly think I want to give them platinum-based chemotherapy, I can still give them single agent, even if they have a low level, 20%, 10% expression, and it's still approved that way. But I agree, I'm most of the time trying to add platinum-based chemotherapy, even though it's approved as a single agent. because I don't think it has just enough oomph, to get us that good response. I'm interested to hear about your feelings with ipilimumab and nivolumab. If you're using that much in any of these settings, really, they have an indication alone as ipilimumab and nivolumab alone, but they also, in the expressors, but then they also have an indication in the negative population. So let's move to that PD-L1 negative population where we're always doing chemo. What about you?
So in the patients that are negative, chemotherapy is really a pillar of treatment in most cases for our patients. As you mentioned, there might be some patients that do have comorbid medical conditions that might prohibit us from using chemotherapy, whether it's hepatotoxicity or hepatic underlying disease or kidney underlying disease. But I will tell you that one of the other drivers in some cases is the patient themselves. I mean, shared decision making is really essential in making that treatment decision. Some patients come equipped with having researched a lot of the data, and they sometimes they will come and say, I absolutely under no circumstances want to receive chemotherapy, but I might consider immune checkpoint therapy. And so that sometimes influences our decision. Well, we might want to include cytotoxic agents if a patient and family really is adamant. We do know we have an opportunity to use the nivolumab ipilimumab combination, with the caveat knowing that the immune-related toxicity profile is going to be higher with that, and we've got to make sure that we're doing our due diligence and assessing for those potential toxicities with that combination.
I haven't felt that it was overwhelmingly higher, though. I feel like ipilimumab and nivolumab doesn't really scare me. I mean, maybe a little bit more colitis, and we'll get to that in our next podcast. Spoiler alert, or teaser there, because we're going to have another podcast talking about toxicities. But I don't think it was overwhelmingly toxic because the doses that we use in lung cancer are not these high doses that were used in many of the melanoma trials. Would you feel the same way?
Well, I would agree with you. That the toxicity profile isn't as high. And you brought up a good point for those listening that maybe are not using immune checkpoint therapies on a regular basis. The scheduling of these, of the immune checkpoint, there's a variety of different schedules that can be used, even within each of those, like pembrolizumab can be used every 3 weeks or every 6 weeks, depending on how stable a patient is. But even, so that might change some of the dosing, but the dosing, particularly of ipilimumab and nivolumab, does change between across the diseases for which it's being prescribed. So that's just an important, little aside for the listeners.
Yeah. So one thing I'd also like to get into is, say you have a patient who has been on chemotherapy and immunotherapy, and their disease is progressing, their cancer is worsening. Do you typically add another immunotherapy in the second line setting or switch to another immunotherapy agent after they're progressing on a checkpoint inhibitor? What has been your experience there?
Well, to be honest, at an academic center, our experience is that we make every effort to enroll patients on clinical trials because there's not a lot of data in terms of sequential use. Some of it's just preference, but really to help look at these, how we sequence treatment regimens, we need the clinical data from trials. So we make every effort to do that. And short of that, if we don't have a clinical trial available, in most cases, we would probably just switch to a cytotoxic regimen for those patients that progressed.
Yeah, I agree. I think also being at an academic center, when patients progress on chemo and immunotherapy, mostly we're looking, if we're going to go to the second line with immunotherapy, it's always going to be a study adding another agent that may or may not be a different immune checkpoint inhibitor. But I don't think that there's really any utility to having a patient on frontline chemo immunotherapy and then switching just to a different immunotherapy, because the mechanism of action, at that point has been used. So they're not likely to respond. But it is unfortunate because now you're going back to just usually single agent chemotherapy or VEGF inhibitor therapy that often doesn't work well for these patients. So it can be really difficult. So going back to these PD-L1 negative patients, I just want to be clear, I'm still using immunotherapy, even though they're PD-L1 negative. We're just using it in combination with chemotherapy. So this goes back to the idea that the PD-L1 is just not a perfect biomarker, which we kind of said in our first podcast, and really can be, misleading when they're negative to say, oh, they're not going to respond. I would still give that patient immunotherapy outside of any contraindications. So, Marianne, any kind of thoughts as we wrap up here as to what you think you would do with any of personal case studies? You had mentioned, patients coming in. If you had a patient who had a negative expression but didn't want chemotherapy, what would you do in that case?
So one thing I just want to mention is that, when we're testing tissue for PD-L1 expression, that's one point of a patient's disease, and it's not representative necessarily of the heterogeneity of metastatic disease. And so that's one thing that, while that tissue may be negative, the patient may actually have expression in other regions. So keeping that in mind really is the underlying reason that, we certainly see patients responding to immune checkpoint inhibition. So I fully support, using the either combination or even single agent immune checkpoint inhibition in patients that either can't receive cytotoxic therapy or are really opposed to it for whatever reason. And we can see responses in these patients. So, we're certainly willing to do that.
Great. Well, I'm going to end on a really happy note. So I just recently attended a targeted therapies conference that was virtual naturally during COVID. And the keynote address was by Dr. Karen Kelly. And she gave a wonderful presentation about curing metastatic lung cancer patients. And, she said there are cases where patients have had complete responses that have been durable for greater than 5 years with immunotherapy. And so I just want to end on that note. Her statement was, this is the future. There have been patients that are likely cured of their cancer. That's not the most common thing, but we've seen this in melanoma, and now we're starting to see some of these cases in lung cancer. So this is really exciting time to be using immunotherapy. And we want to talk about some of those cases because they do happen. They're not the most common thing, but this is not something really that we saw with chemotherapy. So I'm really excited to say that this is something that's possible, that has happened, and hopefully more so in the future. So thank you for joining. Our next podcast will be about toxicities.
Thank you for joining us today. Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/NSCLC5. Look for all of our podcasts on your favorite podcast streaming services.